way down here. We're going to get ready for our next plenary. Is that better? There we go. Thank you, Danny. All right, thank you, everyone. I'm proud to announce our next speaker, Gail Kwame. She is the Assistant Director for Research and Education Services.
That's the old.
And Associate Professor, but that was at her old position. She just changed positions, so now you're...
I'm the Director of the Biomedical Library at University of South Alabama in Mobile as of Friday last week.
So congratulations. Gail, at Augusta, she led a skilled team of librarians embedded in the university's health sciences colleges and units. She worked primarily with undergraduate medical education with a special focus on supporting evidence-based practice as well as participating in case-based learning. Gail's research interests include improving health literacy in vulnerable populations as well as library integration into medical education. She has published works about the librarian roles in small group case-based learning and secured a grant from the National Library of Medicine to provide health education and health literacy skills to incarcerated individuals through secure tablet computers. This grant-funded project was the 2020 winner of the Frank Bradway Rogers Information Advancement Award from the Medical Library Association. And as a fun fact for Gail, she has traveled above the Arctic Circle, so she should be used to the cold weather here in Wisconsin. So everyone, help me welcome Gail. Thank you.
Thank you, Stan. And the updated bio is in your program. Life got a little interesting and dynamic in the last few months, so my husband and I moved to Mobile, Alabama 2 weeks ago, and as I said, I started my new job on Friday, so I kind of just pulled from the position description for the bio to say, well, what it is I do, because I haven't really figured it out yet. I had orientation on Friday, and that's about it. So the work I'm going to be describing today was done when I was at Augusta University in Augusta, Georgia, in the position that Stan mentioned. I was a department head there, the Research and Education Services Department in the library there at Augusta, where the Medical College of Georgia is. And the Masters tournament is taking place this week as we speak. So Augusta gets real crazy this week. People either leave town and rent out their houses for exorbitant amounts of money, or they hunker down and stay off the roads. So it's an interesting place to be during the Masters. So I really appreciate Stan and Wisconsin Health Literacy inviting me to come here today to talk about this unique project, working with an audience that doesn't get enough attention, in my opinion. Our incarcerated people tend to become invisible, and as you'll see as I move into my talk in a few minutes, many people who have been incarcerated re-enter their communities, and we'd like for them to be better equipped when they come out to deal with issues like interacting with a healthcare professional, as well as the other necessities of finding employment and housing and whatnot. Oops. So some of you may not be as familiar with working with this audience, so I thought I would put out just kind of some baseline information and definitions about what we're talking about when we talk about justice-involved peoples. So there is a difference between jails and prisons. Sometimes those terms are used interchangeably, but there is a difference. Jails tend to be shorter-term facilities that are usually administered by local law enforcement agencies. And most jail inmates have a sentence of less than a year, or are being held awaiting trial, or awaiting sentencing, or awaiting transfer to another facility. So a lot of people, and you'll see some statistics in a moment, are moving in and out of our local jails. Prisons are longer-term facilities owned by a state or by the federal government, and they typically hold felons with sentences of more than a year. There are some private prisons as well, but then they are administered by state or federal agencies. So an inmate is somebody who's in custody in a public institution and is being held involuntarily through law enforcement. Someone who is incarcerated is serving a term in prison or jail. The term justice involved has kind of become the preferred terminology for this population, and it's anyone who is currently or has been involved with the criminal justice system, either jail, prison, pre-release, community supervision, probation, parole. So anywhere along that spectrum is somebody who is justice involved. And then returning citizens is the preferred terminology for people who are being released and re-entering the community, and helps remove stigma of labels like ex-con or criminal or ex-offender. So the American criminal justice system holds 2 million people, and you can see the numbers here. That's 1,700 in state prisons, 109 in federal prisons, almost 1,800 in juvenile correctional facilities, over 3,000 in local jails, and 80, and these are the numbers of facilities, I apologize, and 80 Indian country jails. And these numbers don't include military prisons or immigration detention facilities. So the short statement here is there are a lot of people in a lot of facilities across the country. 9 million people cycle through our local jails every year. Again, these are the facilities that have the shorter terms of being there. It's very likely some of you know or have family members that have been incarcerated. 1 in 40 adults are under some form of correctional supervision. What a lot of people don't realize or don't hear about is that 95% of state prisoners will be released and re-enter their community. In a 2018 study, however, it was discovered that 68% of people who were released were re-arrested within 3 years, 79% within 6 years, and 83% within 9 years. So that's a very high level of recidivism, people returning to jail after being released. So this is definitely a health disparities population. So just a quick definition of what that is. A health disparities population is one if there is a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rate in the health disparity population as compared to the health status of the general population. So for this population, we'll show some discrepancies here. So in the justice involved population, 80 to 90% of folks have a chronic health condition as compared to 50% of the general population. Substance abuse disorders, 65 to 85% of justice involved suffer, as opposed to 9% of the general population. And some of this is a result of the war on drugs from a few decades ago. That effect is still persisting today. 63 to 76% of justice involved suffer from mental illness, as opposed to 18% of the general population. Co-occurring mental illness and substance abuse disorder, 45 versus 4. History of past trauma or adverse childhood experiences, 70 to 95% of justice involved as compared to 12%. And this topic is getting a lot more attention. You've probably heard more and more about adverse childhood experiences. There's a screening tool that's being introduced for healthcare providers, especially with children, but hopefully that will transition into something that's being done with adults. Because of issues like this, we're finding that people have suffered trauma, have adverse health outcomes as a result. There's a book about this called The Deepest Well that you may want to consider. Also, educational attainment, high school diploma or GED, 40% of the justice involved population has attained this, as opposed to 84% of the general population. There's disparities about health insurance coverage, and the risk of death from suicide or drug overdose is 10 to 40 times the general population in the justice involved. Some of the chronic conditions that were mentioned on the previous slide include HIV, hepatitis C, TB, diabetes, asthma, and high blood pressure. There was a study done that cited that once released, justice-involved people die at 12 times the rate of the general population. And a lot of this is attributable to limited health literacy, lack of access to healthcare services, and inability to navigate a complex healthcare system. And these are topics that we can all relate to in this audience. So what can be done? And the project I'll be describing was an attempt to address some of this. And the project that won the award that was mentioned in my introduction was inspired by a smaller project that was done at the Gallatin County Jail in Bozeman, Montana. And this was a project in which I was involved from when I was working for one of the regional offices for the network of the National Library of Medicine in Seattle. And Montana was one of the states for which that office had responsibility. And I'll tell a little backstory here because my experience has been that serendipity plays a big part in some of these outreach projects and opportunities. So I met one of the project partners for this particular project at a Health Ministries Association conference in San Antonio, Texas, some years ago. And I was on the agenda to do a talk about health literacy, and I also was staffing an exhibit booth representing the National Library of Medicine at that conference. And he approached me. He has a big heart for health literacy, but is also the chaplain at the Gallatin County Jail in Bozeman, Montana. So we started to talk and have actually ended up doing several projects together, one of which was this initial project about improving health literacy and personal health management of inmates at the Gallatin County Jail. And then he did a second project focusing on health insurance literacy with that same population. And for the project in Bozeman, we brought in health experts surrounding those topics that you saw that were very common for incarcerated people, so hepatitis and HIV and diabetes and high blood pressure, and put together some training modules that were done in person at the jail. There was a VISTA volunteer who was very active on that project and helped recruit people to participate. There was a computer lab in that jail, but as you may or may not know, inmates don't have open access to the World Wide Web or the internet. So sometimes there's an in-house intranet, and some of that has changed where inmates can at least email now. But at the time of this study, there was very limited access to the internet. And so we ended up building an offline system that emulated using the internet, and the folks at the National Library of Medicine were very gracious about letting us upload parts of medlineplus.gov into this offline system. And the idea was that people could practice searching for health information and be prepared for when they were released back into the community. But they also had different training modules uploaded onto those computers and were trained over the course of a couple weeks about these different relevant topics. So this is a list of some of the community partners that participated in that, including the Bozeman Public Library and the library and some of the departments at Montana State University, which is there in Bozeman. So fast forward a few years, and I'm now in Augusta, Georgia at Augusta University, and still had a heart for work with this population and discovered that there is a transition center right in Augusta for men who are less than 6 months from being released back into the community. So they're housed at this facility. Most of them have work release during the day and then return to the facility overnight, but also are getting help starting to apply for work, trying to find housing, different transitional skills to be able to re-enter the community. And so I wanted to find an opportunity to perhaps work with that facility, but also with others. And my pal from Bozeman is still very active in the health literacy world and was a project partner on this grant. So the National Library of Medicine offers these information resource grants to reduce health disparities. And the goal of these is to do bring useful, usable health information to health disparity populations. Well, we've established that the incarcerated are definitely a health disparity population, no question, and the healthcare providers who care for them. And they needed to exploit the capabilities of computer and information technology and health sciences libraries to bring that health-related information to consumers and their healthcare providers. So I did some legwork and discovered that there were several faculty members at Augusta University who were doing research with the incarcerated. Most of them were affiliated with the university's Institute for Public and Preventive Health. And Augusta University is in a very unique position in that they are contracted to provide health care for the state corrections facilities throughout the state of Georgia. So it was kind of a natural fit. And shrinking violet has never been a term that's been applied to me. And so I made some cold calls and contacted the folks at that institute and got invited to start sitting in on some meetings of groups, not just of faculty at the university, but people out in the community who were interested in doing work and research with people who were incarcerated. And they were definitely interested in working on this grant because not only was it a great research opportunity, it was also a service opportunity. So they were very open to having the conversation, and the grant absolutely required the participation of a health sciences librarian, so they needed me. So I kind of pitched my case, and thankfully they went for it, and so we ended up applying for the grant. It was a 3-year, $300,000 award. So we created 4 specific aims for the project. The first one was to do a needs assessment to determine the special health information needs and health coverage eligibility status of justice-involved individuals preparing for reentry into the community. The next was to deliver the health information training modules to justice-involved individuals currently incarcerated, and I'll tell you what ADOVO is in a moment, but incarcerated at partner sites where tablet computers were being used. The third was to then measure the impact that that training had on the level of health literacy, the confidence to improve self-care management, and interactions with healthcare providers. And we really made it hard on ourselves and decided we were going to try to follow a sample of people post-release 6 months after they were released back into the community. And we'll talk about why that may not have been the same if we were to do this again, because it provided some interesting challenges. So ADOVO is a company that's based in Chicago, not too far from here, that provides tablet computers to corrections facilities. And they are not the only company in the US that does this, but what is unique about them is they are mission-driven, and ADOVO stands for Education Over Obstacles. And they are very committed to providing educational materials and self-care materials to people who are incarcerated. And the way these tablets work is they set up an intranet system within the corrections facilities, and the folks who are there are given a login, a unique login and password so they can access the content. And it is possible for the folks at ADOVO then to see what individual people are doing on the tablet computers. And these are also incentivized so that for every hour of educational content people are accessing, they then can access equal number of time on entertainment. So there's television shows, movies, or music that are on the tablets, but they are vetted. What you may not know is that things that are being done at correctional facilities have to be of rehabilitative value and not high violence and that kind of thing. So it's not, they can't watch just anything, but there is a nice selection of materials for them there. So the content is broken down into different categories. And our content was what is called a goal within the ADOVO platform. And it was called Improving Your Health Knowledge. And for the most part, it was short videos, a lot of which had been done by Healthy Roads Media. Are any of you familiar with that group? I see a couple hands. So they provide health information in multiple languages, multiple formats, some of which are videos. And so they allowed for us to, actually Adovo had contracted with them to upload a lot of their videos, and we grouped a lot of them together into these categories that fell into these different themes. And I will say the needs assessment that we did added to the topics that we originally had in mind and that we had originally done in Gallatin County, partly because the needs assessment was deployed to all of the corrections facilities across the U.S. where Adovo had been deployed, had their tablets, which also included females where Gallatin County was an all-male facility. So we got some unique information needs that way, particularly the sexual and reproductive health topic, which had not been done in the original project. But also pain management was another topic that we had not originally considered, but the needs assessment informed that. We were really pleased with the needs assessment data. We had almost 2,000 responses to that survey. And I'll talk a little bit more about kind of the wizard behind the curtain of how this stuff gets pushed out to the folks. So I mentioned we did the needs assessment, and that was administered via the tablets to all of the Adovo partner facilities. And then we did our research study that was also administered via the tablets at 10 participant corrections facilities where the Adovo tablets were already in place, and it took place over 1 year. And I mentioned the transitional center in Augusta, and I will say, sadly, it turned out that they did not end up being a project partner on this. And part of that was because the lawyers got involved. So it turns out there's a difference between state Department of Corrections facilities and local corrections facilities. And it turns out the Transition Center in Augusta is a state Department of Corrections facility, and the Georgia State DOC already had a contract with a different tablet provider. And they were willing to consider deploying the Adovo tablets at the transition facility, but it would have meant getting waivers signed and taking all of this extra time. And our project had already been delayed because in order to participate in a study, what do people have to do? They have to consent, exactly. So first of all, if you've never done work with the incarcerated, the IRB process is interesting because they are considered a special population group because you've literally got a captive audience. So you have to be really careful about the kind of studies that you want to do with incarcerated. In addition, we agreed that consent, as we've all talked about already at some level here, consent forms are horrible in terms of literacy and literacy level and people understanding and people really reading them. And so instead of presenting a wall of text to our participants, we decided we also wanted to provide that language as a video. So production on that got hung up because we were in the waiting line by our production studio on our university campus. So that complicated things. Also, if some of you were here yesterday, you heard about how important incentivization is to get people to participate in projects and studies. So our study was incentivized by allowing people to get up to $50 on what's called a CLIN card. Well, there's a lot of language around these CLIN cards that absolutely had to be included in this consent language. We tried to get permission from our institutional review board to summarize it or curtail it or something, and they said, no, every word of that has to be included. So if you ever want to watch the most gripping 8-minute video, I'm happy to share it with you. But our participants had to go through that consent process either by reading a PDF, which we also had uploaded to the tablets, or by watching that video before they could then participate in the study. So you see there that we had it both ways. And in order to participate, they had to be at least 18 years old and have between 21 and 180 days remaining on their sentence. We thought, in order for it to be meaningful, they needed to have at least a couple, 3 weeks to access the content and internalize it and answer the questionnaires. There was a pre-questionnaire and a post-questionnaire. So the modules I mentioned were grouped as a goal within the Adovo tablet system. Also, the pre- and post-intervention questionnaires were administered via the tablets. And then from the background, Adovo is also able to send out reminder messages to people who may have accessed the content but had not yet completed the questionnaires. And then I mentioned the incentivization. So that up to $50 was done at different stages. So if the first $10 was put on once they consented to do the study, and then the next $10 was added at a different phase, and then they would get the last $30 if they gave us their contact information so we could follow up with them for that 6-month follow-up. And we gave them follow-up contact information in several different modalities: snail mail, email, website, you name it. So anyone participating at the corrections facilities could access the modules. I mean, anybody living there could access our modules, whether or not they were participating in the study also, just so you know. And that content remains to this day on those Adovo tablets. Just all of the study stuff has been stripped out, so nobody has to sign a consent or anything to access it. And they will remain there indefinitely as long as Adovo wants to keep it there. So this video consent, as I said, kind of ended up being a bit of a challenge, but I'm glad we did it in the end. The production quality was quite good, and we highlighted important content by putting, this, if there was something we really wanted them to remember, we would put the text at the bottom of the slide as they were watching the video. So the data about which modules were being accessed was collected, and data dashboards were sent to the research team every week by Adovo. Data from the pre- and post-intervention questionnaires were collected and managed at Adovo as well. So they were a powerhouse in terms of doing a lot of work on the back end in terms of having the system in place to collect this data. And then they provided our research group with the raw questionnaire data, and then we had our number crunchers work on it. So I can't say enough about how nice an organization Adovo was to work with if you're considering doing something like this. So we had 3 sets of questions in the actual study. Some were to measure health literacy, which also included a portion of the newest vital sign. We also had questions about the importance of health behaviors, and then questions about confidence in performing selected health-related behaviors. And some of these questions came from that initial study that was done in Gallatin County. And then we added the newest vital signs questions along with a couple others. And we ran the instrument by a health literacy expert for input, and she gave us some good feedback, and we made some tweaks to the instrument before it was deployed. So for the study itself, we had over 3,000 individuals at participating facilities who accessed at least one of our educational modules. 453 people completed the introductory material and the consent. And of those, 112 completed all phases of the research study. So the data we'll be talking about is based on those 112 people. And all the questions were optional to answer, so not everybody answered every question. And then we had 9 individuals who completed the post-release survey. So, I know these are small, and I apologize, but just to give you a little bit of information about the demographics, the majority of the participants were male, 78%. The majority of the participants were white, 54%. Majority of participants had completed high school at 46%, with the second highest number of participants completing some college, 34%. And, oops, I need to... I don't know if it'll let me do this. age. The most people were within the 25 to 44 age group. 25 was 26%, and 35 to 44 was 36%. So that's almost 60% of the total participants. So of the health literacy questions, what you're looking at here is pre-test and post-test, those bar graphs. And the three that have the asterisks above them are the ones where there was some statistical significance in before and after the intervention. So for the health literacy questions, a significant increase was found overall pre-test to post-test. So that's what this green bar graph is demonstrating, that the overall finding. And then you get down into the individual questions. Three of which had some significance: searching for health information, understanding health status, and the calories part. As you may know, that newest vital sign uses a nutrition label, and there's a question on there about the number of calories. And so that also had a statistical significance. There was no significant differences between gender, race categories, or between education levels. For the health behaviors questions, there was a significant increase from pre-test to post-test. A significant increase was found on all 9 individual questions as well, from pre-test to post-test. So you have questions about contact information, tracking, visits with a healthcare professional, family health history, awareness of mood, engage in preventive care, preparing questions before going to the doctor, reporting symptoms, and health insurance. So again, we were very pleased with these results that indicated that there was a difference pre-test to post-test. And then for the confidence results, 13 of those questions there were 13 questions, 12 of which had statistical significance. So we did a lot of factor analysis, and t-tests found a significance overall, and then, as you can see, significance on a lot of the confidence issues as well. Knowing where to seek care, understanding a medical test, understanding diagnosis, questions about diagnosis, explaining my diagnosis, understanding my needs, questions about medications, seeking a second opinion, questions about self-care, preventive screening, filling out medical forms, and assisting family members. And I will say, from the Gallatin Project, we had some capacity for people to give narrative answers to the questions, and we did on this as well. And one of the participants in the Gallatin study said, I feel so much better prepared to help my elderly parents because of getting this information. So we felt like that was a very positive outcome of that study. And I'll show you some correspondence we received from some of the participants in this study as well. So as I mentioned earlier, we had 9 participants that completed a survey about 6 months after being released. And I'll talk about in a couple minutes about why this is a challenge. But 7 of those 9 reported having some type of health insurance in the last 6 months. 7 of them answered at least 80% of the nutrition label comprehension questions correctly. Now remember, this is 6 months after the previous time we asked them these questions. 7 of them reported currently taking prescribed medication, and 4 of them reported not taking their medication as prescribed. 6 reported visiting a doctor, nurse, or other healthcare provider. 5 reported being involved in treatment programs for mental health problems or substance use or disorders. 5 reported being confident or very confident understanding the medications I am taking, what they are used for, and their side effects. Filling out medical forms by yourself, providing assistance to a friend or family member who has a healthcare need. 4 reported visiting an emergency room or urgent care center, and 4 reported having problems learning about their health because written information is hard to read or understand. So this is some correspondence we got, like hard letters in the mail, because we provided our snail mail address to them. One gentleman said, salutations and thank you for all the opportunities, but this other letter really touched me. This is somebody who's serving a life sentence. He said, I really enjoy participating in the Improving Your Health Knowledge on the Adobo tablet program. If it was not for people like you, people like me would never have the opportunity to better myself. Just because I am never being released doesn't mean I don't want to improve myself. Maybe I can pass on the knowledge to others. So I just thought, what better outcome could you ask for than that from somebody? So we did learn that providing health education paired with self-directed learning, which I think is a really important facet of this, is that these folks are doing this in their own way, at their own pace, picking and choosing the modules that they want, that are important to them, via the secure tablets is an effective method for improving health literacy and self-care management for incarcerated persons. And based on this study, there is not a strong correlation between gender, race, or education and health literacy or self-care management. And I know there's the JAMA study that's been out for quite some time that says health literacy is a stronger predictor of health outcomes than some of these other factors. And I think this kind of, reinforces that as well. So I don't want to say that this didn't come with challenges, because it did. So first of all, just learning to speak each other's language. At the time we partnered with Adobo, they had a couple other research projects going on, but we were pretty early in terms of being a partner that was working on the research project with them. So coming from an academic place versus a company and a private industry, or they're actually a nonprofit business. But just learning how to navigate the waters of speaking each other's language and put library speak on top of that, because I'm a librarian, so that's kind of the filter that I look through. We also had to really, we took pictures of a meeting we had here in Chicago with this big flow chart about, what happens once a person answers this question and then moves on to this and then goes here and then goes there, and making sure that our intent for the research design for this project would still work on their platform, because they knew what was going on in the background and how their system worked, and we didn't really know what could and couldn't be done. Because it's like, well, can you do this and can you do that? And we're like, well, no. So, we had to adapt the research design to fit the technology, and in the end, I think we ended up with a nice product. We also had to make sure we had MOUs in place with the different participating facilities, and that, we keep hearing about gaining trust and making sure we're not exploiting people that are in these facilities. And so the gatekeepers at these corrections facilities are very protective of their people. So it takes a lot of diplomacy and multiple conversations to get buy-in, and then getting something in writing from them that we could submit with the grant package. So, you need to make sure to have lots of time to do that. I mentioned some of the challenges about the video consent, but in the end, I know it was the right thing to do. It did stall our project by some time. We were really hoping to have deployed the study months before it actually got deployed, but in the end, it worked out. And there were, the unknown unknowns. How would we attract this population to this topic? Would they enroll? Would they use and apply the information? So, and of course, the biggest was this post-release follow-up that I mentioned. So once people are getting ready to go back in the community, they're worried about having housing and finding a job and getting reunited with their family. And some of this information may just not be as relevant to them in that moment. But also just figuring out how to contact people. They don't have a cell phone when they walk out and re-enter the community. They may not have an email address. They may not even have a computer. They don't know what their address is going to be yet right away when they're re-entering the community. So, it definitely provides some challenges. There are some policy implications based on some of the lessons that we learned from this project. First of all, there are several tablet providers for corrections facilities, so it's important to do legwork to determine which one is the best fit for your needs. Some of them are simply providing entertainment. Some of them, I'll be very honest, are exploitive and charge money to the inmates to access their content. So be aware, I guess I would say, of the ins and outs of doing this kind of project. You also want to find out, based on our experience, whether the Department of Corrections you plan to work with already has a contract with a tablet provider, and with whom. And that's not impasse. We could have done it, but it would have really delayed our project by having to wait to get these waivers and have the lawyers involved. And in the end, my co-PI had another project that was being funded by SAMHSA with that same facility. And he decided, he didn't want to damage the relationship, and he didn't want to get too bogged down and get that other study compromised, and I agreed. And so we backed away from having that transition center participate. And Adovo's in enough facilities across the country that it all worked out fine. As I mentioned earlier, the IRB process is more complex for working with incarcerated, so do be aware of that and look very carefully at your institution's requirements in getting IRB approval for working with the justice involved. Also, make sure you have buy-in from the participating facilities. The other thing that happened at this Augusta Transition Center is we went and met with the assistant warden, and he was all in. I mean, he gave us a tour, he gave us floor plans. The people from Adovo came from Chicago, and they did measurements, and we're trying to figure out where they would put the wiring and where they would store. There's like a charging cart that the tablets are put in, and you have to find some kind of a central place where people can then come and check them out. It's like a 1-to-2 ratio. It's not one tablet for every person in the facility. It's like 1-to-2 or 1-to-3. So they're in this centralized charging cart, and then at different times of day, people can come and sign them out. So, we thought we were golden with this transition center, and then we set up a conference call with the Department of Corrections and the lawyers, and that's when everything kind of went south. So anyway, make sure you've got buy-in and understand who's doing what. Following up with people once they're released is very challenging. How to communicate, how to stay in touch. So what we did was printed up a bunch of postcards that we sent out to the different corrections facilities, and then they put them, I think in some of these facilities, folks have kind of cubbies that they have access to as they're getting ready to be released into the community. And so the postcards were put in there. But it's definitely a challenge. And as I say, my co-PI and I both said, if we were to do this again, we probably would not do the post-release follow-up phase, maybe come up with a follow-up study to do somehow. But that was really hard. The fact that we got 9 was a success in our eyes. So that's what I have for you today, and I have plenty of time to take some questions. I'm happy to answer some. So thank you very much for your attention. They're dividing and conquering.
I have a question
Okay.
regarding the post follow-up. Do you think that there would be an opportunity to partner with facilities that are like after you
Facilities that are,
like after someone is let out of jail or prison,
so kind of transitional houses.
transitional housing, or is there an opportunity to partner with them to gather more post research? just
So the
wondering
question
if it was
is there an
facilitated.
opportunity to partner with some housing facilities that may be transitional for people that are fully released back into the community? Probably a better avenue would be to go with parole officers, and I know my co-PI has had experience doing that with parolees because they have the contact information for their folks. So, I'm sorry?
Then they can help facilitate that.
They can help facilitate, yes. And so I think he's had pretty good success on his SAMHSA study, working with parolees, and he had done a previous project with parolees as well, where they actually were administered cell phones and were getting, text messages back and forth. It was a substance abuse study that he had done, but finding the right conduit, and that's what you're suggesting, is really important. But I would say the people who are interacting more regularly with justice involved would be the right conduit, because there may or may not be transitional housing in communities, you just don't know. And some of these folks are being incarcerated very far away from home, from where their family is. And so, whether there's a transition facility in Augusta may have nothing to do with whether somebody is, from Macon, Georgia. So it just depends.
Hi, Gail. Sorry.
I can't see you. Oh, hey, Michelle.
Gail and I go back a little ways.
Yes, we do.
Sorry about that. Thanks for your talk. It's really interesting. Opened my eyes to some possible opportunities in the
Great.
work that I do. So I appreciate learning from your experience. But my question is, I thought I heard you say that the Adovo tablets will reside in the system, and I'm thinking, outdated health information is a bad thing.
Right.
And so is there any plan to update those tablets, or what's the plan for keeping them current?
So the question is about the content itself that's been uploaded into the tablets. So the Adovo folks review content on a regular basis. So if it's determined that that gets outdated, it would then be sunsetted, or maybe replaced with a newer version of a video from Healthy Roads Media. And you may remember the gal from Healthy Roads, because she was in the Pacific Northwest. Michelle and I both were in the Pacific Northwest together. She's very committed to making sure she's providing up-to-date and current and authoritative information. So they are, yeah, they have a contract with Healthy Roads to put her material onto the tablets. Yeah. Thank you for the question.
Hi, Gail. Right here.
Thanks.
Dana Demsky. My team is working on producing educational videos for the patient portal.
Yes.
So I'm wondering if you have any tips around what format works best as far as live action versus, illustrated cartoons, or also length of video that seems to be the most engaging. Anything around that?
My understanding is no more than 5 minutes is probably a good standard. For this project, the videos were basically slide presentations with narration. And I like that because it provides, some people learn better by reading, and some people learn better by hearing, and some people learn better by both. And so this provided an opportunity to cover all 3 of those scenarios. So again, kind of getting back to the video consent that I showed you, we did the same thing. We reinforced material that we really, really wanted people to know by putting those captions under the slides as we were talking. Yeah.
Good morning, thank you.
You're welcome.
Could you go back to the slide that shows the number of participants that you had down to the post-release?
Maybe. It's not letting me. I'll let you. I think one more. This one?
Yeah.
Okay.
I don't think that that's surprising that you have the number from 453 up to the first 3,000. What do you think was the reason there's a drop from the people who were initially exposed to the final?
It could be any number of things. So one thing we learned at the Gallatin study is we had dropouts from that study as well, or people who couldn't complete. Because guess what? Your lawyer shows up and needs to have a meeting with you, or your family shows up and needs to have a meeting with you, or you get released sooner than you thought, or you get transferred to somewhere without realizing it. So some of those factors probably contributed, but also it could have to do with just length of time and access to however many modules, or it could just be that they were only interested in 1 or 2 of the topics and didn't really want to do the whole study. So there's certainly a number of factors. And I'll be honest and say I was not disappointed in this number either. It could be that we would have had more participants if our study hadn't been delayed by some of the things I mentioned earlier, and we could have kept it open longer. But the fact that 3,000 people even looked at some of the content was thrilling to me. I mean, that's a win as far as I'm concerned. I'm more concerned about people getting access to the quality health information and less concerned about my study, if you want me to be perfectly honest. The study was great, the grant was great, yay Augusta University. But, for me, we've made this material available to these folks, and they can access it now anytime they want. And that, to me, is more important than the study itself. And I don't listen to that NLM, but, Thank you for the question.
Yes, question. Did the grant cover the costs, or were there other costs involved?
Of deploying the
Of those-
tablets?
The whole process.
The grant covered, we actually were going to use some of the grant monies to put the system into that transitional center that I mentioned, and then we ended up not doing that. But Adovo got a large chunk of the grant for providing so much of the service that they were providing. And then it provided some salary offset for some of the research team. I got a very small percentage. My co-PI got some more, and then our friend in Montana got a small salary offset as well. And then, of course, any travel that was related to going and presenting our findings and that kind of thing. There's a corrections health conference where we presented a couple different times. First, we presented the findings of the needs assessment. And by the way, there's a journal article being published in the Journal of Correctional Healthcare any minute about the findings from our needs assessment, so you're welcome to look that up. And there's another manuscript in the pipeline. So it definitely covered everything that we needed it to cover. Thank you for the question. Yeah. Were there expenses you had in mind specifically that you were curious about? Yeah, so the cost to deploy this system in a facility is about $35,000 for the whole thing. That's installation, the tablets themselves, the charging cart, the whole thing.
Hi, I have a question about the incentive. So for the 3,000, did they also get the additional entertainment component?
Oh, yes, that's a baseline feature of the tablets no matter what. So thanks for clarifying that, yeah.
And the
so-
other question is the 9 individuals, did you offer them any incentive at that point?
They got the full $50 incentive because they followed up after release.
Thank
So
you.
there were 9 total people that got the full $50. Yeah. And we're at the university, and somebody mentioned yesterday during the pre-conference about funders being persnickety about the kinds of cards that you can use as incentive. Well, our university makes that even harder. And you, Augusta, you absolutely had to use these CLIN cards. We could not use any other form of card as an incentive. And the language about these things is silly. I mean, it's like, I call it the blah blah, like when you're getting on a website and you have to consent to the blah blah screen or the yeah screen. I mean, that's kind of what it is. But it's, if you use it at an ATM, you're going to be charged a percentage. You can't do it for this, and you can't do it for that. But that is what we were required to use. And so, we couldn't fight the man on that one, unfortunately. What's that? It was based on the university's policy. Yeah, it didn't have anything to do with the grant. It didn't have anything to do with the National Library of Medicine. It was specifically Augusta University's research office.
Morning.
Hi.
So you had mentioned afterwards all of the material was kind of left on the tablets and they still have access to it. Have you done any post-study research on are people still accessing the data and at what level?
Yeah, we have not, but we certainly could because, as I mentioned, the Adovo people have the capacity to do that. It would be interesting to find out for sure, but you know how it is when you do these things. By the time it's over, you're like, oh gosh, okay, good, it's over. I can breathe for a little while. But yeah, it would be interesting to get that, and we certainly could if we wanted to. Thanks for asking.
Hi, I'm just wondering, was there any involvement with any health staff at the facility? And if so, or I guess if not, is there opportunity there to do some partnering?
There was not direct communication with the healthcare providers at the facilities, other than the participants themselves maybe going to see a healthcare provider while they were there. Augusta is in a very unique position, as I mentioned, because of their relationship with the Department of Corrections in the state of Georgia. And there are lots of opportunities there to do more of this kind of work. I can't say for sure what's going to be done. I was hoping, I was mentioned in my bio that I was really interested in undergraduate medical education, and I really had hoped to develop an elective for our medical students on corrections health. And I know there are some medical schools that are doing that. And our health professions students in Augusta did rotate through some of the corrections facilities as part of their experience. They have a large nursing program and a medical school and some allied health programs at Augusta. And so several of those disciplines do rotate through the corrections facilities. But I would have loved to have had the opportunity, and I had initial conversations with the curriculum associate dean about doing that, and then we all know what happened in 2020. So I think they're still ripe for the picking to do something like that. Because I think, again, this is a patient population as well as community members that merit getting more of our attention.
I'm sorry.
I can't see what.
Okay, I'm right here.
Oh, thank you.
Yeah, my question is, the confidence numbers looked really good in the results.
Yes.
And that is their confidence in their knowledge.
That's right.
Do you think that matches their knowledge?
It's their self-reported confidence about performing those certain tasks. The only way to measure the knowledge itself is that previous suite of questions about, the health literacy questions. Is that kind of what you're asking? Like, does their confidence match or mirror the harder data, as it were, about the health literacy skills? And I don't know that we have crunched the numbers in that way, but we could. It would be an interesting question to ask. And I will posit that to our research team, because as I said, we're still going to be producing some publications about this data. And we also there's a lot of narrative data that came out of this, and we're planning to address that as well. But thank you for that, because that's an interesting slant on that data. Any other questions? All right, well, I really appreciate your time and attention. I know I'm between you and lunch, so. And I'll be here throughout today and tomorrow, and I'm happy to talk with you individually as well. So thank you very much.
Thank you so much, Gail.